Imagine you get like a bug bite on your arm.
Oh, yeah. The worst.
Right. It's annoying. It's super itchy. So you go to your medicine cabinet and rub on a standard over-the-counter anti-itch cream.
And you just expect the itch to fade.
Exactly. But 12 hours later, instead of relief, the area around the bite erupts. I'm talking severe redness, excruciating stinging, and massive fluid-filled blisters.
It's awful. The skin is practically boiling up at that point.
You didn't just fail to treat the bug bite, you just fell headfirst into the benzocaine paradox.
Yeah, it really is one of the most frustrating biological betrayals. I mean, you're reaching for something to soothe your skin, right? And you end up handing your immune system the exact weapon it needs to attack you.
It's wild. So welcome to this deep dive. Our mission today is to synthesize a giant stack of medical sources. We are pulling from the Mayo Clinic, DermNet, the Contact Dermatitis Institute, and some really incredible medical journals.
Lots of heavy hitters today.
For sure. And we're doing this to uncover the hidden complexities of a very common household item. We are zeroing in on this surprising reality that topical over-the-counter anti-itch creams containing an ingredient called benzocaine can actually cause the exact opposite of what they promise on the box.
And, this isn't some rare exotic chemical we're talking about. It is a perfect example of why we need to be incredibly mindful of what we just assume are completely harmless everyday products.
Okay, let's unpack this. Benzocaine is what's known as an ester-type local anesthetic, right?
Correct.
And it is literally everywhere.
Yeah.
Like if you open your bathroom cabinet right now, I guarantee you have a tube of something containing it.
Oh, easily. Sunburn remedies, bug bite creams.
Toothache gels, hemorrhoid ointments. And the mechanism is actually pretty neat. It works by temporarily deadening the nerve endings in the skin locally.
Yeah, it doesn't knock you out or alter your consciousness like a general anesthetic they'd use for surgery.
Right. It just silences the pain and itch signals right at the exact spot where you apply it.
And that highly targeted, localized relief is exactly why benzocaine is so prevalent, because it doesn't have those systemic full-body effects. It's incredibly easy to manufacture.
And, well, easy to sell, right?
Exactly. It's easy to sell over the counter. You don't need a doctor's prescription.
Yeah.
But because it is so readily available, the sheer volume of our exposure to it is astonishingly high.
We're just constantly slathering it on every minor scrape or burn.
We are. And that massive repeated exposure sets the perfect stage for some major immunological issues to develop over time.
Which brings us to the core issue here. We buy these creams to stop an itch. But what exactly is happening under the surface when your skin decides to fight back against the medicine itself?
Well, to understand that, we have to look at how the immune system categorizes threats.
Okay.
Benzocaine is a major sensitizer. In dermatology, a sensitizer is a substance that your immune system might just completely ignore the first 5, 10, or even 20 times you use it.
So it's fine until it isn't.
Exactly. Eventually, a switch flips. The immune system decides this chemical is no longer just a benign cream. It is a foreign invader. And repeated use triggers what we call a delayed type hypersensitivity reaction.
A type 4 cell-mediated response, the sources called it. So this isn't like breathing in pollen and immediately sneezing.
No. This is a slower burn. This isn't just a surface-level irritation from a harsh soap. Your actual immune cells are getting involved in a highly coordinated, targeted attack.
Wow.
Yeah. Instead of soothing the skin, the benzocaine causes allergic contact dermatitis. Your body deploys specific immune cells called T cells to the site, and they flood the area with inflammatory chemicals.
But because it physically requires these cells to travel to the site and coordinate, that's why it's delayed.
You got it. The symptoms don't show up immediately. They typically appear like 12 to 24 hours after you re-expose yourself to the cream.
So you put it on before bed, wake up, think you're totally fine, but by dinner time, your skin is practically falling off.
What's fascinating here is that the patient's perception of the timeline completely masks the culprit.
Oh, how so?
Well, if you apply benzocaine to a rash, you already have, the patient thinks, oh, my bug bite is getting incredibly aggressive.
When in reality, the bug bite itself is totally fine.
Exactly. It is the medicine that is causing a secondary, much more violent allergic rash to just explode right over the original site.
That's crazy. It's like putting out a fire with gasoline. You think you're fighting the monster, but you're actually handing it a protein shake.
That is a very accurate way to look at it.
And this leads to what the medical sources call the itch-scratch cycle. Can you walk us through how people get trapped in that loop?
Okay.
Because it sounds absolutely maddening.
Oh, it is a terrible loop to be stuck in. Picture this. The patient applies the cream to soothe the minor itch, right?
Yeah.
12 hours later, That cell-mediated allergic reaction kicks in, causing a massive new wave of itching, swelling, and blistering.
And they don't know it's the cream.
Right, they're entirely unaware.
Yeah.
They assume their original bug bite or rash is just getting way worse.
Yeah.
So what is their logical next step?
They grab the tube and put on an even thicker layer to stop the new itch.
Precisely, they apply more of the exact same benzocaine cream. This feeds a massive new dose of the allergen directly to those enriched T cells.
Oh, no.
Yeah, which causes an even more severe reaction 12 hours later. They are locked in a vicious cycle where the treatment is the actual pathogen driving the disease.
That is wild. And look, if it's this bad on the thick, relatively tough skin of your arm or leg, what happens when people use this stuff on areas where the skin barrier is practically non-existent? Because a lot of these products are specifically marketed for ground zero genital and mucosal skin.
Yes, moving to mucosal and genital environments changes the rules of the game entirely.
I can imagine.
The genital region is uniquely susceptible to contact dermatitis for a few structural reasons. You have incredibly delicate tissue, a constantly moist environment, and frequent exposure to friction from clothing and daily movement.
And just looking at the pharmacy shelves, benzocaine is heavily featured in products meant for exactly these sensitive areas.
Oh, everywhere.
You have over-the-counter vaginal itch creams, hemorrhoid ointments, and it's even used as a desensitizing agent in some condoms to, like, delay ejaculation.
Right. And the skin barrier in these regions is already highly permeable compared to, say, the skin on your forearm. It absorbs chemicals rapidly.
So the benzocaine just rushes right in.
Exactly. And this vulnerability is severely exacerbated by certain physiological changes. For instance, postmenopausal women often experience a drop in estrogen levels.
Okay, and what does that do to the skin?
It leads to a condition called genitourinary syndrome of menopause, or GSM, where the vaginal lining and vulval skin physically thin out.
Wow.
Yeah, and when that delicate tissue thins, its barrier function drops dramatically. It makes it a prime, highly vulnerable target for severe allergic reactions from these over-the-counter creams.
But I have to ask about our modern habits here, too, because it feels like there is this cultural obsession with extreme hygiene, especially around sensitive areas.
Yes, absolutely.
People are using heavily scented soaps, feminine hygiene sprays, wet wipes. Does all that overzealous cleaning basically strip off whatever natural armor the skin has left, making the benzocaine creams even more damaging?
This raises an important question about how our daily habits actively sabotage our medical treatments.
Yeah.
Yes. Cultural norms around aggressive genital cleaning actively degrade the skin's outermost protective layer.
So we're doing it to ourselves.
Pretty much. Your skin has something called an acid mantle. It's a very fine, slightly acidic film on the surface that acts as a barrier to bacteria and chemicals.
Okay.
When you use alkaline soaps and scented wipes, you are stripping away those natural oils and completely neutralizing that acid mantle.
So you are basically blowing the doors off the hinges.
Exactly. When the barrier is compromised like that, a known sensitizer like benzocaine doesn't just sit on the surface doing its job, it penetrates much deeper into the living layers of the skin.
And that's what triggers the massive inflammatory response from the immune system.
You got it. It's rapid and severe.
And once the immune system decides it hates benzocaine, it doesn't just stop there. The sources get into this crazy phenomenon where an allergy to this one specific anti-itch cream reveals a hidden web of other seemingly unrelated chemical allergies.
Yeah, the cross-reactivity.
Right. We're talking cross-reactions with hair dyes, sunscreens, and even a condition called burning mouth syndrome.
This is where we have to look at the underlying chemistry of the molecule itself.
Okay, let's get into the chemistry.
Benzocaine is derived from a chemical called para-aminobenzoic acid, or PABE.
Pabo, right. Like the old sunscreens used to say, Pabo free.
Exactly that one. So if your immune system becomes sensitized and learns to attack benzocaine, you are highly likely to experience cross-reactivity with other chemicals that are also derived from PABE.
Here's where it gets really interesting. You think you are just allergic to a hemorrhoid cream, but suddenly your body is reacting to paraphenylalanidyne PPD, which is the main chemical found in permanent dark hair dyes. Or you start reacting to sulfonamide antibiotics, sulfa drugs, or azozo dyes used to color the clothing you wear, or even PABA-based sunscreens.
The immune system doesn't read the label on the bottle. It is essentially recognizing the structural shape of the chemical molecule.
It's pattern matching.
Exactly. Because the hair dye chemical and benzocaine share a very similar structure, specifically an amino group on a benzene ring, the immune cells look at both of them and just launch an attack.
Which is terrifying.
It is. Doctors actually documented this wild scenario regarding this cross-reactivity, specifically focusing on a condition called oridemia, which is burning mouth syndrome.
Yes. Walk us through those case studies from the journals because they perfectly illustrate this invisible chemical web we are all walking through.
So there were two women, ages 52 and 58. Both were dealing with an inflammatory condition in their mouths called oral lichen planus.
Which sounds painful on its own.
Very. So to manage the pain, they were both prescribed a 20% benzocaine gel to numb their gums.
Pretty standard treatment.
Right. But instead of relief, both women experienced extreme, agonizing burning and stinging inside their mouths. The oridemia.
It sounds miserable.
It was. And the 52-year-old also developed a highly itchy, red, blistering rash on her lips, the corners of her mouth, and even on her index and middle fingers.
Presumably from where she was applying the gel with her hand, right?
Exactly. And when the dermatologist finally did the detective work and ran patch tests, the results were a total revelation.
What did they find?
Both tested positive for a massive benzocaine allergy. But the 52-year-old also had a severe reaction to PPD. It turns out she had been exposed to it years prior when she used to apply dark hair dye for her friends.
Wow.
And the 58-year-old strongly reacted to balsam of Peru, which is a common flavoring agent found in everyday toothpaste.
It really highlights how interconnected our chemical exposures are. I look at it like biological guilt by association.
That's a great analogy.
Like, the immune system is acting like a bouncer at a club checking IDs. It sees the hair dye chemical, recognizes the face on the ID because it looks almost exactly like the benzocaine it already hates, and immediately throws it out.
Yep, no questions asked.
But here is what I don't get. The sources say that if you have had past exposure to these cross-sensitizing allergens like the hair dye, it actually speeds up how fast you react to benzocaine.
It does, yeah.
Normally, it takes a while to become sensitized, but these cross-reactions happen at warp speed. How does past exposure hit the fast-forward button on an allergy?
It comes down to immunological memory. When the 52-year-old was dyeing hair years ago, her immune system didn't just fight off the chemical. It built a specific population of memory T cells targeted at that PPD molecule.
Like a sleeper cell.
Think of them exactly as sleeper agents. Those memory cells go completely dormant, quietly patrolling the bloodstream for years. Fast forward a decade, and she applies benzocaine to her gums.
And because benzocaine looks like PPD to the bouncer, the sleeper agents wake up.
Exactly. Those pre-existing memory T cells wake up immediately. They don't need days or weeks to figure out what this new chemical is or how to fight it. They already have the exact blueprint for an attack.
Wow.
So within 48 to 72 hours, they mount a full-scale, aggressive inflammatory response.
That is terrifyingly efficient. But while a blistering rash or a burning mouth is incredibly uncomfortable, our sources highlight another side effect of benzocaine that isn't an allergy at all.
Right, something entirely different.
It is a genuine drop-everything medical emergency. We need to talk about the oxygen thief.
If we connect this to the bigger picture, we move away from localized immune responses on the skin to a systemic, life-threatening blood disorder.
Okay, let's get into it.
The condition is called methemoglobinemia.
Let's break that mechanism down because it is a big word with massive implications. What exactly is the benzocaine doing to the blood?
Well, inside your red blood cells, you have hemoglobin. That is the protein responsible for carrying oxygen from your lungs to the rest of your body.
Basic biology, right?
Right. Benzocaine has a toxic mechanism where it causes the iron within that hemoglobin to oxidize. It chemically changes state.
Okay.
This altered, mutated form of hemoglobin is called methemoglobin.
Let's use an analogy here just to make sure I'm getting this. If normal hemoglobin is like a delivery truck that picks up oxygen at the lungs and unloads it at the brain, what does methemoglobin do?
In that analogy, methemoglobin is a delivery truck where the doors have been completely rusted shut.
Oh, wow.
Yeah, the truck still picks up the oxygen cargo, but it binds to that oxygen so tightly that it refuses to open the doors and release it to the surrounding tissues.
So the oxygen is there, it's just trapped.
In medical terms, we say it shifts the oxygen dissociation curve to the left. Your blood might be pumping full of oxygen, but your organs and tissues are actively starving for it.
Which results in severe hypoxia.
Exactly.
The symptoms sound terrifying. The Mayo Clinic notes that patients can develop pale, gray, or blue-colored skin, lips, or nail beds.
Yes, cyanosis.
They get a fast heartbeat, shortness of breath, and severe confusion as the brain is suffocating while the blood is literally flowing right through it.
It's incredibly dangerous.
It is so dangerous that the Mayo Clinic strongly advises against ever using benzocaine products in children under 2 years old, particularly for things like teething pain.
It is a critical warning. Infants simply do not have the metabolic enzymes fully developed to convert that methemoglobin back into normal functioning hemoglobin.
So the oxygen starvation just compounds rapidly.
Yes, very rapidly.
But, if you're listening to this and thinking, okay, but I'm an adult, I just use a tiny dot of this benzocaine spray, a gel on a canker sore, so I'm fine. Are they actually safe? Does it only happen if you bathe in this stuff?
That is the most important safety question we can ask. While methemoglobinemia most often occurs when patients receive a very large dose, usually in a clinical setting like a hospital endoscopy where a lot of numbing spray is used down the throat, the medical literature is extremely clear.
It can happen at home.
It can and does occur with small amounts, even from over-the-counter use at home. This is especially true for high-risk groups.
Like who?
Infants, the elderly, and people with specific hereditary red blood cell disorders, like G6PD deficiency. They are at a highly elevated risk even with minimal exposure. You just cannot assume a tiny dot is universally safe.
Okay, so we have established that this incredibly common cream can trap you in a horrific itch cycle. It can trigger a cascade of related chemical allergies to things you use every day and potentially suffocate your cells from the inside out.
Quite a resume for an over-the-counter cream.
So what does this all mean? If someone suspects they are trapped in this cycle, how do doctors actually figure out you have this allergy, and what are the safer alternatives?
Well, the gold standard for diagnosing allergic contact dermatitis is patch testing.
Right.
A dermatologist applies small amounts of various suspected allergens to your back, using little chambers taped to your skin.
I always picture this as a slow-motion police lineup for chemicals on your back.
That's a fun way to picture it.
But I have a huge question about this. You just told me my immune system has these highly trained memory T cells ready to attack. So why on earth does the patch test take so long?
Ah, I see what you're asking.
The patches are left on for days, and readings are taken at 48 and 96 hours. Shouldn't the reaction be instant, like if someone with a peanut allergy eats a peanut?
It is a great distinction. It goes back to the difference between an immediate allergy like peanuts or bee stings, where your body releases antibodies that trigger an instant flood of histamine, and the cell-mediated allergy we see with benzocaine.
So no histamine flood.
In this case, no. There is no instant histamine release. It physically takes time for those specific memory T cells to migrate through the bloodstream, arrive at the skin on your back where the patch is, recognize the allergen, and release the chemicals that cause the visible swelling and redness.
Oh, wow.
Yeah, it is a slow, physical, cellular infantry deployment, not a chemical explosion. So it takes 48 to 96 hours to actually see the battlefield form on your skin.
That makes a lot of sense, actually. The troops literally have to march to the site.
It's exactly.
And the sources note some interesting nuances in how they test for it, too. The standard North American baseline test just uses a 5% benzocaine mix in petrolatum.
Right, the baseline series.
But the European baseline series upgraded to something called Cane Mix 3, which is a 10% mix of benzocaine along with dibucaine and tetracaine. They did that specifically to increase the sensitivity of the test to catch more people who might be slipping through the cracks and are allergic to the broader family of these chemicals.
Exactly. And once diagnosed, the primary non-negotiable treatment is absolute, strict avoidance of the allergen. You have to read every single label.
Avoidance is key.
For the acute blistering rash itself, doctors will typically prescribe topical corticosteroids to tell the immune system to stand down, along with bland emollients to help repair that broken skin barrier.
But there is a massive flashing warning sign in the medical guidelines about those emollients, specifically the oil-based ones, especially when you are treating genital dermatitis.
Oh, this is so important.
If you are using an oil-based moisturizer or ointment in that area, it can severely degrade latex condoms, causing them to break or split almost immediately.
Yes.
Plus, those heavy oil-based creams can soak into your clothing and bedding and become highly flammable. You have to be incredibly careful with how you treat the reaction.
It is a vital safety point. If you just need a barrier to protect the skin while it heals, plain petrolatum is often recommended because it's inert.
Okay, that makes sense.
Now, if you still legitimately need a local anesthetic for pain, but you're allergic to benzocaine, the safe alternative is usually an amide-based anesthetic, like lidocaine.
Lidocaine, why is that safe?
Because lidocaine is structurally completely different and does not contain that PABA chemical base, it generally does not cross-react. The bouncer at the club doesn't recognize it.
But even then, we can't just slap lidocaine on without a care. The medicine might be safe, but the delivery system matters, right?
Right. The active ingredient, lidocaine, might be perfectly fine for you, but the cream itself contains a vehicle to carry the drug into the skin.
Like the inactive ingredients.
Exactly. Vehicles like propylene glycol or various preservatives are themselves known irritants and potential allergens.
Yeah.
You might switch to lidocaine and still get a terrible rash because your immune system is reacting to the propylene glycol in the base cream.
So constant vigilance and reading the inactive ingredient lists are absolutely mandatory.
Mandatory. No exceptions.
Well, this has been a massive paradigm shift. We started by looking at a simple, everyday tube of over-the-counter anti-itch cream.
Something so basic.
Right. And we uncovered that it can trigger a paradoxical itch-scratch cycle that makes your skin infinitely worse. It can unearth hidden cross allergies to things as random as hair dye and toothpaste. And it can even pose a severe oxygen-starving systemic risk to your entire bloodstream.
It really highlights the immense value of paying close attention to exactly what we are putting on our bodies, especially in those highly sensitive, vulnerable areas.
And that is the ultimate takeaway for you listening today.
Absolutely. True knowledge is not just about hoarding interesting facts from medical journals. It is about applying that knowledge to make safer, more critical choices. The next time you are standing in the pharmacy aisle, looking at a massive wall of instant fixes, you now have the context to read that label, understand the mechanism of action, and protect your own skin barrier.
It leaves me with a lingering thought, though. In our modern world, we are so conditioned to seek out an instant, over-the-counter fix to numb every single minor discomfort.
For sure.
A tiny itch, a slight burn. We immediately reach for the chemical silencer. But by constantly bombarding our skin with these powerful chemical sensitizers, are we inadvertently training our immune systems to be hyperreactive? Are we fundamentally making our bodies intolerant to the natural environment around us just to avoid a brief moment of mild discomfort? It brings us right back to the beginning. Sometimes in our rush to fix a problem, we might just be handing our bodies the weapon it uses against us. It is definitely something to ponder the next time you reach for the medicine cabinet. Until next time.